Well, this is a really challenging population, and unfortunately this is a population that has poor outcome in general no matter what is done. And so what we really want to do is to maintain patients' quality of life, minimize toxicities of treatments, minimize hospitalization, and really maximize opportunities for patients. I try to think in terms of milestones for my patients and really focus with them when I have conversations about really what to expect in terms of how frequently they may need to come to the doctor for transfusion support, how much risk they're willing to entail, and it's a very challenging population in that setting. With that said, that doesn't mean there aren't very interesting options that are coming down the pike. I think we've seen some real advances here. There's been emerging data about using hypomethylating agents alone or in combination with other agents to really target this population with agents that may be more effective than intensive chemotherapy, which really adds a lot of toxicity. So some of the hypomethylating agent combinations are actually really quite exciting. Ones that jump to mind include venetoclax as an addition to azacitidine or decitabine. There's a clinical trial looking at that right now. There's also a study looking at vatustuximab talarine, or SGM33A, which is a ADC, an antibody drug conjugate that targets CD33. And with both of those combinations, they're seeing really remarkably high response rates in patients with very little additional toxicity to what would be expected over the hypomethylating agent alone, and that's why it's being looked at in now the phase 3 setting. So that's really exciting that these combinations may be quite tolerable in this population. The other thing that's being looked at, again, in a targeted way, is the combination of FLT3 inhibitors with hypomethylating agents for those patients. And again, the IDH inhibitor trials are starting to move earlier and earlier, so we're excited to see how that works there.